Okay, I guess we are live now. So, welcome to the TRT and Hormone Optimization YouTube channel. And back with us as a guest is Gil T. Welcome back, Gil.
Thanks, Stephen. Appreciate it. Always good to be here with you.
Great to have you back. I know you're a preferred guest of many in the Facebook group.
It's much appreciated.
So, for everyone watching this live stream, or maybe you're watching this after the live, we have a new Facebook group because the previous one with 17,000 members was deleted by Facebook for no reason whatsoever. So, we started all over. So, you can find a link to the Facebook group with the same name as the channel under this video. And the link and the Gil and a lot of other providers are in there as well, helping guys out on a regular basis. So thank you for joining us there.
Of
Before we get
course.
new questions in the chat box, there are already some coming in. Let me have a few questions, Gil, that were already prepared or sent in before. First, this one. Somebody asked, can you give us some reasons men quit testosterone replacement therapy?
Some reasons why someone may quit.
Yeah.
So, I am of a belief that if you begin testosterone replacement for the correct reasons, you should stay on it forever. Now, my office will not start someone on testosterone for any reason outside of what we deem to be a medical deficiency. Medical deficiencies are not necessarily defined by clinical numbers in and of themselves as a guideline, but that is certainly a part of it. They are also defined by lifestyle variables, age, symptoms, etc. So if we determine you are deficient or that the potential risks, which we mitigate quite well, are minimal compared to the potential reward of going on therapy, we will initiate therapy. And generally, that will be a lifelong or presumably, hopefully, a lifelong venture. We don't feel that there's a reason to ever come off testosterone replacement when it's managed correctly or when you get on for the right reasons. And therefore, I see no medical reason for someone to discontinue treatment unless there are environmental factors or self destructive factors. So, for example, I will not treat smokers. I will not treat people who are severely or morbidly obese. I will make sure that all of that is addressed prior to initiating therapy. And that is because the risk associated of liability to us is greater with those individuals. With that said, that is just my philosophy on treatment. With that said, there are people who often choose to come off for various reasons. It could be a personal decision, which I don't necessarily have to agree with, but I have to respect from a patient's perspective. Or it may be another provider who disagrees with the treatment and talks the patient into coming off, which again, I don't have to agree with, but oftentimes I have to sort of mitigate. Why people come off? People come off because they feel that they're not feeling a tangible benefit to treatment, which oftentimes I try to tell patients there's many intangible benefits that you may not necessarily feel. It doesn't mean the treatment's not working for you. It just means that if your symptoms are unresolved by treatment, perhaps those specific symptoms are secondary to other causes, which you should explore. Sometimes people have a provider who doesn't feel that they should be on testosterone, whether it be a urologist, endocrinologist, cardiologist, or primary care provider, and they talk them into coming off treatment. Again, I don't necessarily agree with it, but those are the most common reasons that I see why men discontinue treatment. Like I said, I don't agree with them, but those are probably the most common.
Sure. Yeah, and the common reasons like high hematocrit or a PSA that is too high, all those things.
Right. That's usually why another provider will tell them to come off. Again, we don't necessarily agree with that philosophy. We believe that the testosterone in and of itself does not cause harm in those scenarios. But if those scenarios exist, they should be explored for the main culprit or the reason why they exist, and that should be rectified rather than just pulling someone off therapy and allowing them to suffer and oftentimes they just spiral into worse health overall. So, but yeah, a lot of people believe that testosterone is the evil force behind some of these unwanted outcomes, and
Yeah.
it's a shame.
Yeah. I had another question. Yeah. Somebody asks, what are some natural testosterone boosters that I could use while on TRT?
Well, you're not going to boost testosterone while you're on TRT because you are replacing it with testosterone. If you want to rephrase the question to be more logical and say something along the lines of what are some things that I can do myself while on TRT to enhance the benefits I feel from my treatment, then that would be a more valid question. It wouldn't necessarily be to enhance your testosterone, it would be to enhance your life. And one of the biggest things that anyone can do, whether they're on testosterone or not, is improve the quality of their sleep by getting more hours of sleep, by trying to be more restful prior to falling asleep, by removing electronics and all artificial light prior to going to sleep, by reducing caffeine intake throughout the day, especially as the day goes on. And by exercising and improving circulation and breathing. Once you do all of that, you'll have more energy, you'll have better sleep, you'll have better rest, you'll have better recovery, you'll have less brain fog. And that coupled with the synergistic effect of optimal testosterone levels will yield a better life overall. They're not going to boost your testosterone numbers because, again, that is regulated by your medication, but they are going to amplify the result that you feel from being on therapy. So sleep would be number one, and then anything related to sleep and stress reduction, whether it be nutrition, exercise, etc., is probably going to be the biggest thing that you could do for yourself. It doesn't come in pill form. On one hand, I'm sorry to say that because I know it's easy to just take a vitamin and forget it. On the other hand, it should make you excited because you fully control that aspect. You don't have to rely on going out and buying a supplement.
Mhm. I know Jordan talked about this also a while ago, but I wanted to ask you as well. What are some TRT clinic red flags? Because that's very important to a lot of guys coming into the groups, newbies to this channel.
So I'm going to give you the big picture of what a red flag is to me, and then I'm going to dive into the micro details of why that is a red flag. The biggest red flag to me as a provider of testosterone to thousands of men around the country is when someone is on TRT through a provider who accepts health insurance. Not to say that the fact that you accept health insurance necessarily means that you're doing things differently, but it always turns out to be that way. Providers who accept insurance are paid in a model where they have to do volume. You literally cannot make a living as a provider if you are seeing a low volume of patients on a day-to-day basis. If you're seeing 1 to 2 patients per hour with insurance, you cannot make a living. All insurance-based models operate on a 30 to 50 patient a day scenario, and you only get paid for the office visits, so they have to drag you in. By definition, providers who are insurance-based or credentialed with insurance companies for reimbursement do not optimize the level of studying and research and clinical experience and literally building their entire practice around dosing hormones correctly for men. And the reason for that is not what pays their bills. That is a small portion of where they actually make their living. The big part of where they make their living is other areas of medicine. And because of that, they will never do a good job compared to someone who literally just focuses on this one aspect, who is a subspecialist of the specialty. Us as subspecialists, we cannot accept insurance because insurance doesn't pay us what we need to be paid in order to do the job that we do for the amount of people that we do it for. So a provider who accepts insurance, by definition of the way the system is designed, will not do a proper job on men's hormones. So insurance-based providers, first red flag for me. Second red flag, even with all the testosterone clinics that are cash-based, if they check things like estrogen or estradiol in a man, they clearly do not understand the intricacies of endocrinology versus intracrinology versus metabolites or exogenous hormones or how all of this plays together. So if they test your estradiol It is a red flag. If they prescribe, and I don't care if they don't prescribe it to you, and I don't care if they said only use it if you need it, and I don't care if they said you don't need it for now, but you may need it in the future. If they ever wrote a prescription to any man for an aromatase inhibitor, they are completely clueless about anything to do with men's hormones. You need to leave that clinic immediately, even if they don't force it on you. If it is in their repertoire, they are a bad clinic. Period. End of story. We can spend the next hour explaining why. We won't do it here, but we have plenty of videos on this. So again, they prescribe an aromatase inhibitor to anyone. Garbage clinic. Period. End of story. So don't test estrogen, don't block estrogen. Those are the two big ones. If you're seeking insurance-based providers, you're going about this the completely wrong way. Those are probably the top red flags. If they have a guideline of numbers where they say if your total T is here, you qualify. If it's here, you don't qualify. That's utter nonsense because they're chasing numbers. If they make you donate blood every 2 months, 3 months, 4 months continuously and an ongoing, never ending cycle, terrible clinic, get out fast. If they try to prescribe you, a dozen different medications to counteract side effects from the other medications they give you, if they prescribe you anabolic steroids like oxandrolone and androlone and all this other nonsense, get out. They are a money grab. They are a steroid clinic. They are not going to look out for your health. You may feel great initially. You're going to shorten your lifespan and you're going to run into a slew of problems down the line. So unfortunately, all of the things I just mentioned are the norm and the commonality in this industry. All red flags. All red flags. Terrible.
Yeah. Sure. Another question. Okay. Yeah, I had a question about IGF-1. Do you ever use IGF-1 in your clinic? Does it have a place in the HRT business?
We don't prescribe IGF-1 LR3 because it is heavily scrutinized, and we try to keep a clean operation. We try to take care of patients from a health first perspective while also staying within various guidelines of FDA and other regulatory agencies. And I feel we can do a good job as we have, both making patients happy and healthier while also maintaining a clean line of licensure and keeping regulators happy. So we don't use that particular peptide. What we do use is we use other IGF-1 or growth hormone secretagogues like Samorlin, which is FDA approved for humans. We use Tesamorlin, which is very similar to Samorlin, has a better affinity for visceral fat reduction. It does tend to be a little pricier than Samorlin, which is why both options are very viable. Both of those do a great job with IGF-1, and they are safer than a lot of the other things out there. Testosterone in and of itself generally tends to raise IGF-1 levels as well. So when a man initiates TRT and it's done correctly and managed correctly, you'll notice an upswing in IGF-1 over time as well, even in the absence of any IGF analog or secretagogue.
Mm-hmm. So it's not your
And
opinion
sleep.
that... Yeah.
I'm sorry,
Yeah.
and quality sleep will help IGF-1 as well.
Sure.
And a reduction in carbohydrates.
Mm-hmm. So it's not your opinion that every man 45, 50 that is already optimized on testosterone should also explore using GH or an analog?
I'm very cautious in using the word every man because when you make a blanket statement like that, you're encompassing everyone and you're taking away the ability to assess people as individuals. Saying every man, no, there are contraindications to IGF-1 elevations, for example, the known presence of cancer. Right? We know that cancer is proliferated with an increase in IGF-1. And if someone has known and present cancer, then obviously it's contraindicated. If someone is a type 2 diabetic or insulin resistant or pre-diabetic or has an elevated A1C or elevated fasted sugar or elevated insulin levels, all of those things may potentially be contraindicated for IGF-1 therapy. So to say every man, absolutely not. To say a lot of men can benefit from it, yes, considering all of these conditions have been discussed, assessed, and taken into account before issuing a prescription.
Mm-hmm. If I remember correctly, you do prefer secretagogues above HGH, right?
Absolutely. We have never and never will prescribe recombinant human growth hormone because when you prescribe an exogenous hormone, much like we do with testosterone, we know that there's a couple of things that occur. First and foremost, you have suppression. And that suppression with testosterone is fine because you are suppressing something that is already deficient and presumably needs to be replaced indefinitely. When you're suppressing growth hormone, considering the fact that there are much bigger risks and significant side effect profiles and contraindications that testosterone generally does not have, and it's significantly a very pricey endeavor, this is not something you want to do forever. And you don't want to suppress someone's ability to release growth hormone out of their pituitary, because if that condition becomes irreversible or becomes deficient to an extent in the future where they're dependent on this exogenous medication, you're relegating them to a position where they may not be able to get that medication due to cost prohibition, due to regulatory issues, or due to side effect profile issues that make it a contraindication. And if any of those conditions exist, this individual is now in a world of trouble. So I don't like them for that reason, coupled by the fact that from a regulatory standpoint, they are heavily scrutinized. So secretagogues are significantly safer, and you don't run all of those risks, including acromegaly and cardiomegaly, and progressing type 2 diabetes and progressing existing cancers, all things that are significantly less profound with a secretagogue compared to a synthetic exogenous growth hormone.
Yeah, all right. Let me have a look in the chat box. A recurring question, and I already know what you're going to answer, Gil, but adding Anavar to TRT for someone that is lean and pretty muscular, what are your thoughts about it?
I hate the word Anavar because that drug has not existed since the 90s. And the only people that still use that terminology are bodybuilders. And I completely try to separate myself and my offices from anything to do with bodybuilding or illegal steroids. So I will not refer to the term Anavar, but I understand that he's referring to oxandrolone, which is still a prescription. Now, the FDA in the United States has stopped approval for oxandrolone. It is no longer a drug that is FDA approved for humans in America. With that said, we do not prescribe it. It does have a side effect profile that does contraindicate a lot of different conditions. It is indicated specifically for muscle wasting, specifically in 3 scenarios: HIV patients, chemotherapy patients, and burn victims who have a severe catabolic syndrome going on. So it is a muscle wasting inhibitor in those 3 conditions. That's the FDA indication. It has been taken off the market about 2 years ago. And even prior to that, due to scrutiny and being a class 3 controlled, that really has to fall within a tight margin of indication. We've never prescribed it, and we don't plan on it. So that's my take on oxandrolone.
Sure. Mehmet says, I feel much better when I add a little bit of testo gel on top of the injection. Could this be due to more DHT?
I would venture to say probably a little more placebo effect, because gel in and of itself is pretty atrocious. It's 1.62% testosterone per volume. Absorption is not that great, and it just doesn't work that well. It's probably more of a placebo effect because you think it works, so it does. I mean, your DHT, again, is an intracrine hormone, much like estradiol, and it's self-regulated intracellularly. So applying the gel is not going to give you more DHT than just taking your testosterone injections, assuming you're on a proper protocol.
There's a question. Late 20, early 30s, sperm banking done. When do you consider moving from lifestyle or fertility preservation options to TRT in this younger population?
Just like I would with any other patient, we do a needs analysis. What is the condition of the current individual? What is his diagnosis? If he has a sign of low testosterone coupled with symptoms that correlate to low testosterone, coupled with the fact that we have a diagnosis, whether it's pituitary failure, testicular failure, hypothalamic failure, or it's self-induced due to a poor lifestyle. Once we have all of that data, now we can sit down and assess what is the plan of action for that individual. And if fertility is a concern, then obviously it's a conversation to have. Thankfully, these days we do have really good adjunct therapies to testosterone where we can re-implement fertility treatments when the time comes. So it's less of a concern than it used to be. With that said, I'm not going to treat somebody who's 30 necessarily differently than someone who is 40. I'm still going to do that full assessment from the diagnosis phase all the way through the patient education so that they can make an informed decision.
Sure. Gus asks, at what point should a physician or patient be concerned with elevated creatinine?
So creatinine is one of those things that's a little bit tricky. Ever since the early 90s, when creatine monohydrate became available as a widely used supplement that's over the counter, it is by far been the most studied over the counter supplement, and it has been proven to be very safe, specifically when people are hydrating well and using it in conjunction with a good exercise program. It is the most abundant protein found in muscle tissue. And unfortunately, a lot of labs in hospitals are still going back to creatinine levels in order to assess kidney function. So when you look at estimated GFR for kidney health, the biggest variable in that formula is your creatinine. And when you take exogenous creatinine or creatine through supplementation, your creatinine levels are always going to be falsely elevated. It's not necessarily due to a lack of efficacy of kidney filtration as much as it is to an overload of blood serum levels due to supplementation. The problem is that you're going to set off alarms when you go to any primary care for a well visit, or if you go into a hospital, expect a significant workup from a nephrologist. When your creatinine comes back at 1.4, 1.5, et cetera, they're going to assume kidney damage. So I think that the more acceptable forms of testing these days, whether it be a 24-hour urine analysis or more recently a cystatin C, those are more indicative of kidney health rather than just looking at creatinine levels. I wouldn't be too concerned with someone who's got a little more muscle mass than average or someone who exercises heavily, which breaks down protein, muscle protein, and dumps creatinine into the blood, or someone who supplements exogenous creatine. All of those peoples are going to have elevated creatinine. And one of the things that I always preach on here is expected findings are not alarming. The problem is that a lot of your providers don't have expected findings. They just kind of look within the flags. So understanding the mechanism of a treatment or what's going on and doing a proper assessment really gives you an idea of what an expected finding should be prior to even opening. I'll do my subjective assessment prior to looking at the objective data, because I'll go into the objective data with a mindset of what I'm already expecting to see based on the feedback I've received.
You can write, I take transdermal scrotal cream twice a day. I was at 830 nanograms per deciliter at my 12-hour trough. Do you have any idea what I peak at? An educated guess.
I'd love to give you one. It would literally be an uneducated guess because I don't think anyone could really, answer what you specifically, based on that dose on that day with that base of cream, absorbed and then metabolized into your circulation. There's no way to know. And I'll be honest with you, don't worry about it. If you feel good on your protocol, go out there, enjoy your life, be happy with it. Don't worry about the number. If you were at 800 something on your trough and you feel that, maybe I was 12 or 15 or 17 or 11 or 1,000 on my peak, who cares? If you feel good, your symptoms are resolved, all other biomarkers on your labs look good, your provider doesn't have any concerns for you, then you shouldn't have concerns. You should just go out there and enjoy. Don't worry about the number so much. The total T number is really more of a measure of an ongoing trend coupled with SHBG, coupled with other factors. And it really shouldn't be something that people spend all this time and effort chasing. So I truly don't know what your peak would have been, nor do I think that you really should be that concerned over it either.
Agree. Yeah. Do you give a defined trial period for lifestyle changes before adding medication for the younger guys?
Yeah, I really hate to relegate a young man, and again, the word young is subjective, right? Let's call it early to mid 20s. Even late 20s is a young man, but specifically, I get a lot of guys for some reason between 20 and 25 that come in. And it's not a bad thing. I don't dislike seeing them come in for an assessment. I do dislike seeing them come in as a transfer patient already on testosterone
Mhm.
because I feel a lot of them are misdiagnosed because the sign of low testosterone does not necessarily mean that they belong on testosterone therapy at 22 or 23 years old. When they come in suppressed on therapy from another clinic and they want us to take over care, and we often do, it pains me to see this because you're relegating a young man who may not have needed this treatment at this point to a lifetime of treatment before you gave him a fair chance to really optimize his body naturally and fully figure out what was wrong and maybe just make a couple of tweaks to improve his health. But when we get a new fresh guy and we come in and we do the full gamut of assessment from luteinizing hormone to SHBG to sleep patterns, et cetera, I have no complaints about that whatsoever because it doesn't mean that just because you did an intake and did a consultation in labs that we're going to place you on testosterone. In fact, I'd say that more than 50% of the guys that come to us under the age of 25 end up leaving my office not prescribed testosterone, but they walk away with knowledge and information on what they could and should do to enhance their life and then maybe save another decade before they do come back in and require any sort of intervention.
Mhm.
So I would not rush to put a young man on testosterone. I hate to see it. Some do need it. Some truly need it, but I hate to see it because every couple of years we notice that the generational gap between men on treatment and men who need treatment starts to go down and down and down. And now they're really young, right? So I don't like seeing guys in their 20s on TRT, but very few actually need it. Most just kind of want it and just play along. But I really try to not prescribe it to younger men unless it's really really needed.
You said you don't treat obese guys. Um, do they
Morbidly obese.
need to reach a certain body mass index before you will treat them? And if
Yeah,
will
I'm
putting them
sorry.
on testosterone not help them lose weight or put in the
Good
effort to do it?
good question. So a couple of different things to address. First of all, I didn't say I don't treat obese. I said morbidly obese. Okay.
Okay.
Unfortunately, most of America is obese. Okay. So if I didn't treat obesity, I wouldn't be here. Morbidly obese. And when I say treat, I was referring specifically to testosterone. I do treat anyone and everyone according to what I feel is going to benefit that individual in the short term. Because if I want to give you a long-term treatment, the first thing that I have to do responsibly and ethically, I owe you the opportunity to assess what's going on and tell you, look, I feel that ultimately you're going to need this, but before we get there, the current risks outweigh the benefits. Therefore, let's bring you into a position where we can start doing this safely. If you take a man who is 6 foot, 300 pounds, okay, that is morbidly obese. That is somebody who is far more likely to die than the average person. Okay, he's about 100 pounds more than someone his size should be. That's not somebody who's got a BMI of 30 or 29. That's somebody who's got a BMI of like north of 35, right? Then you couple that with the fact that I can almost bet my left arm that he has obstructive sleep apnea due to obesity. I could also bet you that he's got some form of metabolic syndrome because let's face it, the lifestyle that got him to that body weight is probably not the healthiest lifestyle. So he's not as active. He's sedentary. He's got a terrible diet. He doesn't sleep well. He may be a smoker, maybe not. He's probably stressed, probably got some form of depression. All right, because you can't tell me you're walking around 100 pounds overweight and you're happy as can be. So at the end of the day, when you look at the picture of the whole person, and you say to yourself, if I put this man on testosterone today, first, his likelihood of dying, not because of testosterone, just in general, right, is higher significantly than an average guy. That puts me under scrutiny and under potential risk for liability, which I'm not willing to accept anymore. Because it's just unfortunately that's just the way the industry is right now. Secondly, the initial spike of aldosterone, which may increase, hypervolemic hypertension risk for a period of months, coupled with what we already determined to be a bad diet, which is why he's obese, right? That is a risk in and of itself. That's a cardiovascular risk, and I'm not willing to increase his cardiovascular risk, which is already present. So there's a lot of factors playing into this where I'm not going to put a band-aid on a broken leg. We need to fix the underlying issue here. Will testosterone ultimately help this man? Sure. Is he ready for testosterone today? No, the risks are too great, both legally and medically. So what we need to do is we need to maybe get this guy on a meal plan. We need to get this guy on an exercise plan. We need to get this guy on a GLP-1 for weight loss. And a lot of these guys who are receptive to these ideas do come back to us in 3, 4, 5, 6 months, and they're down 60 and 70 pounds, and now we initiate TRT. A lot of these guys say, no, I just want TRT, and they go about their way, and guess what? 6 months later, we may see them again, and now they're 320 pounds. They're going in the wrong direction because they refuse to accept responsibility for what brought them here, and they just wanted a medication rather than actually putting in the effort. I am not going to reward self-destructive behavior with pharmacology. I'm going to reward productive behavior and an initiative and accountability with assistance and guidance and maybe a little bit of medication. So it's more so a decision of, look, we're very busy. We have more patience than time, and we're very selective in helping those who want to help. And the way to prove that you want to help is to show me that you're willing to help yourself. Because if I want you to succeed more than you want to succeed, we have a problem.
Sure. Another very good question there from Shannon. What red flags do you listen for that tell you a patient is not ready for the commitment of TRT?
People who are very gung-ho about TRT before we even have a conversation about their diagnosis, about anything. People who tell me they've gone to 3 or 4 clinics trying to get TRT and they've been turned away. They're just kind of shopping for who's willing to write the prescription. People who walk in looking like they are ready for Mr. Olympia stage next week. Again, not to say that they don't necessarily need it. It's just that I've been doing this long enough to understand who's shopping for drugs and who truly needs therapy. I try to listen to the symptoms. See, this is medicine, right? This is not a diner where you walk in and say, I'll have the steak and eggs. This is a place where you walk in and you say, here's what I'm feeling, here's what I don't like, and here's what I'd like to feel. And it's up to your provider to assess and suggest what you need to get you there. It is not up to a patient to walk in and say, here's a list of drugs that I'd like, right? It's like in the hospital, you always have the people that come in and shop for the pain medication. If you come in and complain of pain, we'll assess the pain and prescribe what we feel we need to heal you. You don't get to come in and say, here's the drugs that I want to purchase today. That's not how medicine works. Unfortunately, with a lot of clinics, it does. When people send us messages on social media and say, do you have a price list? That boils my blood. This isn't a takeout menu. What do you mean? A price list for what? I'm not a drug dealer, right? So those are very big red flags. And it just, unfortunately, it's the nature of the industry that we're in. But we don't play in that game, and we try to avoid it as much as possible.
Yeah. We have the same thing in a dermatologist or cosmetologist's office when people write you an email and they ask the price for the Botox per unit. It's like they're shopping for a painter for paint or whatever.
They're looking for the lowest bidder out there. I mean, it's like per unit. Well, it depends on which company we're using, how many units you're going to need. Like, you need to assess somebody before you could say, they're like, no, I know how many units I need. Okay, well, good luck to you.
Yeah, it's like asking Da Vinci how much the paint costs. I always say so.
Right. I get guys sending us emails and say, how much for 180 milligrams a week? Well, first of all, I don't know if I'm going to prescribe you anything. Secondly, I don't know if I'm going to prescribe you that dose. Like, you don't get to tell us what drug we're willing to prescribe and what dose we're willing to prescribe. You get to tell us how you feel. We get to present you with a treatment option. Then you get to accept or decline. That's how it works.
There's a remark here. Hemoglobin 18.3, hematocrit 55.3. I know my doctor is going to say something. 150 a week divided into 3 injections. I tested 903 nanograms per deciliter yesterday.
Okay.
What do you think about those numbers, Gil? Should his doctor be worried?
I think that worried, not necessarily. Now, unless this is a obese individual with other comorbidities, in and of itself, those numbers don't scare me. But we do have to consider that testosterone therapy, especially the protocol he's on, which I don't know much about him, but it sounds like a very reasonable protocol of 50 milligrams 3 times a week. You know, underwhelming and not anything that I would blink at and say jumps out from a testosterone perspective. Testosterone has been shown to increase hemoglobin and hematocrit levels in most men by an average of about 10% from baseline. If your baseline was already, 10% less than it is today, then you were high to begin with. So the question is, why was it high to begin with? Are you a smoker? Do you have sleep apnea? Do you snore? Do you live at high elevation? These are all questions that should have been asked on his baseline. And if they weren't, it's never too late. We would ask them now. If the answer is yes to any of these questions, now we go back and assess, well, if he lives in Flagstaff, Colorado, then it's, or Flagstaff is Arizona, I believe. I'm sorry. If you live in Flagstaff, right, elevation 8,000 feet, then again, expected finding, unremarkable, no big deal. If you tell me I live in, Maine at sea level, and I smoke cigarettes, well, I never would have started you on TRT to begin with if you smoke cigarettes. Because again, now you're a high risk patient. If you're obese and you have sleep apnea, well, go get your sleep study done, get a properly fitted CPAP, use it every night, and address the issue. Testosterone is not what's causing erythrocytosis at that level in an otherwise healthy male. If he is healthy and he's an athlete, I wouldn't necessarily bat an eye, but I would continue to trend and figure out why it's creeping up. If he is unhealthy, then yeah, you may want to intervene here. But again, more information is needed. But I would look at outside of testosterone factors as to why this is happening to him rather than blame the 50 milligrams 3 times a week.
Just to repeat what we have said in many other videos, there's no reason to donate blood at this point, right?
No, no. Again, you have to assess why is this happening to somebody on that dose. And I can assure you it's not from his TRT. It shouldn't be.
And you already talked before about good hydration. Many men who go in for a blood exam, they aren't hydrated after a long night as well. So
Right.
you advised before to hydrate well before the
Always.
blood donation.
2 reasons. Number one, the blood flows much better when you're hydrated. And number two, your hematocrit isn't going to be artificially elevated because it is a dilution ratio.
Are there
Now, with
any
that said, if he's at 55, I'm sorry, if he's at 55, it's not like drinking 2 bottles of water is going to bring him down to 45. He may drop 0.2 of a point, right? So he's still going to set off the red flag at the lab, but it's still better to be hydrated. But like I said earlier, assess why this is happening. This is not in and of itself just dehydration at that point, and it's certainly not from his 150 milligram dose.
Are there any other reasons to be better hydrated on TRT than not on TRT?
Yeah, what we discussed earlier regarding creatinine, you tend to have more muscle mass and elevated creatinine level. Men on TRT is just proven they tend to be more active and exercise more. So they break down more muscle tissue and more protein in the blood. It means a little more work for the kidneys. And the biggest problem with kidney failure is a lack of hydration, right? Which is the big age-old debate between cardiologists and nephrologists. Cardiologists want water pills because heart failure, they want to get the water out, but then nephrologists say, no, I'm not putting the guy on a diuretic because you're going to destroy his kidneys. That constant battle. So if you care about your kidneys, hydrate, especially if you lift weights and you have higher creatinine and you're on TRT. Hydration is just good for every living creature. But if you already have higher protein in your blood, you need more hydration to save your kidneys. Your liver's forgiving, your kidneys are not.
Something I wanted to ask you as well, Gil. Nowadays, it's been a little bit of a hype here, especially in dermatology. A lot of patients are asking me about using DHEA solo as a supplement for anti-aging reasons. What do you think about that?
The word anti-aging is such a broad term. I see it more as a marketing term, right? What does it mean? You have to define what that means. All right. Does it mean less wrinkles on your face? Does it mean more energy? Like, what is anti-aging, right?
Mhm.
Um, so it's hard to kind of answer it in that regard. DHEA in and of itself, look, it's non-suppressive. I will say from the studies I've seen and anecdotally speaking to providers who are more, I guess, knowledgeable in the pro hormones, like Dave Lee, for example, DHEA is more potent in females than it is in men. Uh, as monotherapy, I do see it as a good adjunct to TRT when needed if there is a deficiency. Where I tend to use it with guys more is if they have like a sensitivity issue or if they have a delayed like anorgasmia or delayed ejaculation scenario. I find that 25 milligrams of DHA in the morning may in some guys coupled with HCG may improve that particular symptom. I also find that some men actually don't feel well on DHEA. The nice thing about it is it's an oral and you could take it. And then if you say that, hey, I don't feel as good when I'm on this, then you can stop. And 2 to 3 days later, it's gone and out of your system. So DHEA is another one of those things. It's not a blanket, one size fits all, but it's a trial and error type of a thing. As monotherapy, I can't see it making a tremendous dent in someone who's truly deficient. If you have suboptimal testosterone and you're relatively young and you do have a DHEA deficiency, a supplement may improve your total. But as standalone therapy, I can't see it making a tremendous dent. I'm not going to say it's going to take a hypogonadal male and give him optimal testosterone just because he took DHEA in the morning.
Yeah, sure. But people are asking about this without any symptoms, without any blood exams. They just want to try it as an anti-aging supplement, really.
Fine, try it. I can't see it really harming you.
Hmm.
And if it has a placebo effect and you feel it's making you feel better, God bless. It's,
Yeah.
it's over the counter in America. I know a lot of countries it's by prescription, but you can buy it on, most over the counter supplement stores.
Hmm. What are your thoughts on fertility during TRT? Do you need to stay on HCG always, or can you jump on it when Clomid possibly with Clomid possibly when you want to conceive?
So I never prescribe Clomid to anyone. I hate it. I have videos on the channel specifically about Clomid. Um, You don't necessarily have to be on HCG, but I also tell guys HCG doesn't work for everyone. It works for men who have pituitary hypofunction with well-functioning testicles. If your Leydig cells are working well, HCG will stimulate them. If your Leydig cells are dead, meaning primary hypogonadism or testicular hypofunction, then HCG in and of itself is not really going to do much because it is an LH analog. So guys with low T coupled with supra-physiological luteinizing hormone levels on their initial labs are not going to benefit from HCG whatsoever because they're just replenishing something that was never deficient in the first place. So HCG is something that needs to be assessed. It's not a one-size-fits-all, and I'm mind blown by how many providers don't quite understand this concept, let alone how many patients are out there thinking it's just, oh, take HCG, no problem. But HCG in and of itself is generally insufficient for proper spermatogenesis to occur in terms of volume and motility. You do need FSH, and FSH as an adjunct to HCG while on TRT, I have found works best for fertility in terms of odds of conception, coupled with a low-cost ovulation kit for the female. And then you have to time things correctly. So I have a whole fertility protocol that we educate our patients on when it is time to conceive. And thankfully, we've had pretty good success of people conceiving within 1 to 3 months of getting on our fertility protocol with a little bit of education.
Awesome. Alfonso, thanks for the super chat. What are your thoughts, Gil, on the peptide kisspeptin for fertility and TRT? How does it compare to HCG, HMG?
So HMG, unfortunately, or human menopausal gonadotropin, is no longer available to prescribe in the US. at least in the compounded form. There may be some commercially available ones, but they're very expensive. I think somewhere in the $1,500 range for a vial. My understanding, Kisspeptin, which we do not prescribe because we do have access to HCG as well as FSH, which I find to be superior. I think Kisspeptin is more of a GnRH analog. So it stimulates the pituitary to produce luteinizing hormone, whereas HCG mimics luteinizing hormone. So it's a step down. That's really all I know about it. We've never used it with any of our patients because I just don't see a need to. HCG is widely available from us and it's very affordable. So that's just what we've had a lot of success with over the last decade.
Okay. Gil, you mentioned cardiomegaly with GH. Does that occur at 2 or 3 units?
Well, 3 is 50% more than 2. So I know it doesn't sound like a big difference, but that's a big difference, right? $150 is a lot more than $100, even though it's only $50, it's 50%. The standard dosing for recombinant growth hormone or the synthetic exogenous form is 2 IUs per day, and it is a progression. It is not the 2 IUs today. It's the 2 plus 2 plus 2 plus 2 for a year that leads to the effects. Now, obviously, it is dose dependent, but it's also patient dependent. So yes, over time, you have to consider that even without growth hormone, without testosterone, without IGF-1, people do develop LVH at the very least over the course of their lifespan, whether it's through hypertension or through just being an athlete. So the heart as a muscle will grow over time the more you put strain on it, whether it's blood pressure related or exercise related. Now you're adding in synthetic growth hormone, which is super physiological, which we know declines with age, and now you're replacing it with age when the heart muscle is already more susceptible to these conditions. Yes, LVH coupled with cardiomegaly is still prevalent even at the lower dose with growth hormone, obviously not as much as an abusive dose, but the risk nonetheless does not disappear.
An interesting question, Gil. I saw a patient of mine a few weeks ago, and he's 51, 52, something like that, and he's an airline pilot, and he's on TRT. I guess it was injections, 150 milligrams per week, something like that. He feels awesome. He's all optimized, but since he's been on TRT, his systolic pressure has been going up a little bit, 130, 140. But at his medical exam for being a pilot, he was told if that continues like that, they will grant. So is it because of the TRT, and what should he do about it?
So I'm actually a commercial multi-engine rated pilot here in the US, right? So I have a lot of pilot patients. And we have, similar to Europe, we have, the FAA does conduct medicals, and depending on your age, they're anywhere from 6 months to a year to 2 years, depending on the class of medical coupled with your age. And blood pressure, obviously, coupled with diabetes and other factors, vision, et cetera, are things that are all checked. And there's a couple of things. So first and foremost, he can, at least in the US, he can go on blood pressure medication, and as long as it's well controlled, it's not a problem. Second, like we discussed earlier, all steroids, specifically anabolic steroids, like testosterone, will increase other steroids, like aldosterone, which is a mineral corticosteroid from the adrenals, which acts on the kidneys, and it helps to reabsorb sodium, and with that comes water retention. So we have to remember that when somebody has more volume in their blood vessels, whether it's water or otherwise, it's called hypervolemic hypertension, right? Or blood pressure as a result of just having more blood volume. So the things he could do is increase his cardiovascular endurance to have better circulation. He could also take a low dose blood pressure medication. He could take a little bit of hydrochlorothiazide, which is a first line for blood pressure, especially hypervolemic. And he could also take a low dose daily tadalafil. And I hate to say this here because I'm not trying to make people game the system, but if he was to hypothetically take a little bit of Viagra before he took his blood pressure, then for a matter of a couple of hours, his blood pressure would be lower.
Mm. Yeah, exactly. Yeah, but going on low dose blood pressure medication, I think is the best option,
Yeah.
right? Yeah.
Yeah, as long as he's, he could take a little hydrochlorothiazide with a little potassium, and
Yeah.
yeah.
Next to that, he's very fit. He doesn't drink alcohol, doesn't smoke. He's a very fit guy. He's a pilot. So, yeah. All right. So, let me just check. I had some other questions there. Um,
Bear with me 1 second because my battery's at 4%. While you look through a couple questions, I'm going to make a quick run for the charger.
sure. No
I'll be
worries.
right back.
No worries. Oh, yeah.
And by the way, I can still hear you in my headphones.
Yeah, I still hear you.
So if you want to ask, I can start answering.
Yeah, we'll wait. No worries. If anyone watching has still questions for Gil, it's the moment now to post them in the chat box. 10 or 15 more minutes. And if you're watching now, give this video a thumbs up. This helps the algorithm. All right.
All right, I'm with you.
Yeah. I had a few other questions. One was about the range of free testosterone. I know if you already stated that on the channel many times, you don't like just blanket numbers. But people are always asking about free testosterone ranges. But is it really important? Is it the free testosterone that makes you feel better?
Yes, but that doesn't mean that everything else is moot. Free testosterone is certainly essential. And, everyone always wants ranges, right? So I'm going to give you a range, but I'm going to give it to you with an asterisk. And that asterisk is that it is not a range that is a one size fits all. There are people that feel better slightly below. There are very rare few people that do need a little bit more. And I hate saying that because every guys always think more is better with testosterone, so they're always going to say, "Hey, I'm the guy that needs more." And I will tell you, there are a lot of side effects that come with higher free T, and oftentimes what guys refer to as estrogen side effects, they're actually high free T side effects.
Mm.
So that comes from crushing their SHBG with improper protocols, and that lowers your total T, which makes them think they need more T, which actually exacerbates the problem of further lowering SHBG and increasing free T. It's a vicious cycle, which is very difficult to explain to patients. When I train providers, I put this on a whiteboard to make sense of it for them, but it's a little hard for people to visualize until they truly understand what's going on. Free T, most of my guys, I would say 90% of my men report feeling symptom resolution to an extent when their free T falls in a range of between 20 nanograms per deciliter and 35 nanograms per deciliter. That is generally where you're going to find the biggest proportion of people who report resolution to some of the symptoms on their Adams score. You're going to have the outliers below where they may be at 17, 18 nanograms and they feel great. You may have the guys that, in that range that don't feel well and you got to push them a little bit, and that's rare. But overall, I would say in an anagram scenario, that is where most fall in. And I will say that a lot of labs check picograms per milliliter. You got to move the decimal over to the left one to convert to nanograms. And then you have nanomoles over in Europe, which is a completely different formula. That is 28.8 multiple to get the nanogram number. So you got to do a little bit of math. But here's the thing, to alleviate all this possible confusion, my answer is always the same: find a competent provider who truly understands this stuff, and then the rest will just fall into place.
Mm-hmm. Yeah. Again, back to the HGH. Why is it that the secretagogues don't cause cardiomegaly if they both increase IGF?
Good question. The answer is because they are something that naturally occurs within the body. So, in other words, the concept is that your body will never self destruct when it's secreting its own substances. When the body does self-destruct, we have a name for that. It's called cancer, right? So in the absence of cancer, your body only produces what it can substantially handle without any negative side effects. With that said, if you stay on a secretagogue for a long period of time, and as I said earlier, even if you're deficient over the course of time, you're still going to have a larger heart than you had when you were younger, just due to time, just wear and tear. All right. It's one of those muscles that will grow the more you're alive and the more it beats and the more your blood pressure goes up. Everyone develops hypertension with age just due to vascular resistance. Body systems start to deteriorate, kidneys start to deteriorate, the efficacy of your heart starts to deteriorate, the left ventricle lining starts to thicken, which makes the lumen or the cavity of the left ventricle smaller, which means that the amount of blood you're able to pump with each pulse is lower, and therefore you're going to have more strain on your heart. When your heart is strained, it works harder. When a muscle works harder, it grows.
Mm-hmm.
So, heart failure, if you live long enough, is inevitable. And now when you're coupling that with higher level of supraphysiological hormones that help the muscle grow, it's going to be exacerbated. Secretagogues do not allow your body to get into a supraphysiological range because, by definition, supraphysiological means above the limits of your physiological capabilities. And a secretagogue simply pushes you to your physiological capability.
Mm-hmm.
So I know it's a little complicated. I hope that makes sense, though.
It makes sense to me.
Right.
Do the
You're, you're,
secret,
you're a little more medically inclined than most.
yeah. Do the secretagogues keep on working even in older men? Maybe when their pituitary gland isn't that good anymore?
Good question. Keep working is subjective. It's not a well-defined term. The answer is yes. Will they optimize? Depends on how good the gland that is being provoked. Will they optimize in a 90-year-old the same way as they'll optimize in a 40-year-old? Presumably not,
Mm-hmm.
right? Depends on the individual, but presumably not. Will they push a 90-year-old past where he is currently? Yes. Yeah. I mean, if you poke something with a stick, it's going to respond more than if you don't poke it. So
Okay.
provoking a gland to do something will yield a response. How good is the response is going to be dependent on that individual at that point of time and their health.
So there's not a certain point of or age that you should switch to GH because the secretagogues don't work anymore.
If you switch to growth hormone, I feel, forget even from a liability litigation standpoint, from a medical health standpoint, I feel that the risk of exogenous growth hormone outweighs the benefit.
Okay, that's clear. How does Gil feel about supplementing a TRT regime with DHT cream, mainly for improved libido?
Supplementing or replacing?
Supplementing.
Never tried it myself, never tried it with my patients. Can't give you a fair assessment. I can't say that I oppose it. So my answer would be try it and see how you feel if you're inclined to do so. But I will say that again, DHT in and of itself, much like estradiol, is an intracrine self-regulated hormone. Morgenthaler talks all the time about the saturation model. And I feel that if you have optimal TRT that is correctly managed, your DHT and other metabolites will fully be saturated. And any exogenous introduction of that hormone or metabolite is just going to be spillover. So your blood serum may show an improvement. I don't think that's necessarily going to translate into any tangible benefit, but prove me wrong. And I'm not saying it to debate. I'm saying try it and see how you feel. Maybe you're the anomaly. Maybe you'll feel better. Maybe it's placebo. But I don't have experience with the exogenous DHT creams.
Oh. All right, so I think we're 1 hour in. So if people want to work with you, Gil, how can they reach you? And do you work in every state?
In the United States, my offices do treat via telemedicine nationwide. We are licensed nationwide. We can get you blood draws done at either LabCorp, or we can have a phlebotomist come to your home anywhere in the country and do your labs for you. And then we can treat you and prescribe you over the phone. We have thousands of patients around the country. You can go to elevatewellnessgroup.com, click on the telemedicine link, put your name, phone number, and email. My office reaches out to close to 100 people per day. I have 4 girls full time on the phone just answering those inquiries every single day. They will call you, they will email you, they will text you, but they will get a hold of you if you fill that out. ElevateWellnessGroup.com, click on the telemed section and just input your information. You will get a contact within the next business day.
Yeah, and there's a link to Gil's business in the description of each video he appears in.
Yeah,
All
that
right,
one
Gil.
is next. The one in your links is Next Level Dietetics. From there, if you choose to click that, I will direct you to my clinic if you're in the United States. If you're overseas, then we can do an informational consultation over Zoom. We just can't get you a prescription if you're not in the US.
Yeah, sure. All right, Gil. Thank you so much for your time and sharing your knowledge once again.
Always a pleasure. Thank you so much. Good to see you. And that beard looks good on you. I like it.
Just temporary, like everything.
Okay. Nothing wrong with that. Thank you,
Thank you
Steve.
so much, Gil. See you next time.
Take care.
Bye-bye.
Yep.